mental health wards from reactive firefighting to providing proactive care, something I'm really fascinated in hearing more about. So just to let you know a little bit about John before we hand over. John's been part of the team here at the NIHR Patient Safety Research Collaboration for a number of years now, and he was appointed to Chair of Mental Health Nursing at the School of Healthcare at the University of Leeds back in 2015, so 10 years ago now. John, you've been in that role. His research focuses on improving quality and safety of mental health care, and he has a focus particularly on reducing coercion and restrictive practices, patient and professional safety and mental health services, and developing effective and therapeutic mental health services. So some three really important areas of research there. He also currently chairs the NIHR Doctoral Clinical and Practitioner Academic Fellowship scheme. And I was interested to learn this from his biography, that he's Adjunct Professor at the Forensic Mental Health Research Unit in Middelfart in Denmark. And that's a long-held role. And John has been a registered nurse for over 30 years. I know he doesn't look old enough, but apparently that's what it says on his biography. So again, delighted, John, that you can join us today to talk about some of the work that you've been doing over the past 5 years. I'll hand over to you now. Thank you.
Thank you, Rebecca. I'm keeping my eye on the chat. I know when you guys start talking, you won't actually, I won't be able to see any of you anyway, so it doesn't really make a difference if your cameras are on or off. Let's share the screen and make sure that's working. And into presenter mode. Fabulous. That's the first technical hitch over and done with. Hi, my name's John. I'm a long-standing mental health nurse, as Rebecca said, and it is 30 years I've been registered as a mental health nurse. So where does time fly? What you'll see is we're going to talk about moving or trying to think about the way wards are managed and the way that mental health wards, but all wards, I think, pretty much the NHS is always on its back foot. It's always reactive and firefighting. And actually, are there things we can do to start changing that dynamic from being on the back foot to actually being more proactive in thinking about the way we provide care? And in doing so, hopefully that will reduce the number of incidents we might see and improve the quality of care we provide. If you want to know more, there's these little QR codes on some of the slides that will take you directly to the publications that run alongside this. And this work's probably been going on for a lot longer than just the last 5 years. So the first QR code will take you to the very first paper I wrote 25 years ago, where, strangely enough, I was arguing about changing mental health inpatient care from being reactive firefighters to providing proactive care. So for those new to research, it takes an awful long time to actually do anything and change stuff, but maybe we're getting there. As with all research, this isn't me. This is about a massive team effort. There's been loads of people that have contributed to the work that I'm presenting today and the publications that run alongside that. I hope I've listed everybody. If I haven't, please accept my apologies. But I think I've got everybody down who's been part of this journey. Disclosure, this was funded by the NIHR, and we did get some help from the PSTRC, as was. These are my views, not anybody else's. So let's start on this journey. Are acute mental health wards safe? No, they're not. But we've got 30 years worth of literature saying that. And a lot of that literature has come from patient experience and service users' perspectives. And when we talk about safety, we need to think broader than just, these hotbeds of violence and homicide and suicide. There's lots of stuff goes on wards that make them unsafe. There is suicides, unfortunately, and there are occasional deaths, but they're the tip of an iceberg. And actually, we need to think about the whole picture. Now, when you talk to clinicians, they often talk about this clinical changing picture. So, acuity is rising. We're seeing more and more detentions in the Mental Health Act. Problems around coercion and the use of restrictive practices, which would be a whole nother talk. And I've spent just as long thinking about trying to reduce coercion on wards as I have around patient safety. Individually, though, patients are no worse today than they were 10 years, 20, 30 years ago. And I think that narrative around acuity is actually quite needs to be challenged, because actually it makes nurses put their hands up and say, well, there's nothing we can do. Patients are worse today than they've ever been. And that narrative's always been there within nursing, within acute mental health nursing. But what we are seeing is a concentration of people. So, deinstitutionalization started many, many years ago, 40, 50 years ago, and it's gone on to this day. We've got less and less beds for acute mental health people when they're distressed and they need admission to hospital. And actually, the design of those units is pretty shoddy. They're not designed with space and therapeutic environments in mind. So you're concentrating people in very small, clamped, contained areas where you can't even open a window. The doors are increasingly locked. So is it any wonder that things feel worse? We're also seeing concurrently with that, this kind of change in skills and workforce. There are 4 fields of nursing. We often forget this, and mental health nursing is a distinct field, although over recent years, the training has felt more generic. So mental health nurses have a lot more times thinking about physical health skills than maybe they did around mental health skills. You're also seeing lots of replacement and substitution of registered mental health nurses on wards, largely because there just isn't enough of them. So for the last 15, 20 years, there's been a decline in the number of mental health nurses on the register. And that, I think, is really impacting on the kind of care we're able to provide to patients on wards. So what does unsafe look like? This was one of our first projects where we asked all 32 acute mental health wards across the 5 trusts in Yorkshire and Humber to give us 3-month snapshot of their incident data. We were quite interested to see what would be recorded and what's actually there within the systems. So we managed to get 3,000 incident records that were put into Datex over a really small 3-month period. And for those of you that work in kind of district general hospitals or general hospitals, the feeling around Datex is probably very different in a mental health context. Very different things are reported. Very different things are seen as safety incidents. So what you see is this kind of smorgasbord of stuff, which range from they're listed nicely alphabetically, but from absconsion right through to violence and aggression. But actually, there's some really concerning things you see in Datex reports. Things around sexual abuse and sexual assaults. You see things around fires, deaths, and some really quite disturbing things. And remember that actually ward suicides and ward homicides are very small. They don't happen very often, but actually there's an awful lot of other things that are going on in wards, which are really quite traumatic for patients and to some extent really traumatic for staff as well. So you end up with both staff and patients becoming traumatized from being in this constant chaos of an acute mental health ward. If we try and make sense of that in a bit more detail, there's some things that really kind of stand out to me, that actually of all of those 3,000 incidents that were reported, 90% of them were categorized as low or no harm, which to me is really surprising, given that the vast majority of incidents on wards that are recorded are around violence and aggression and self-harm. They constitute about 80% of all incidents on wards, and we've seen an increase over the last 10 years, specifically around the self-harm on wards. And thinking about how we manage that is a whole different story that Hannah's, one of my PhD students, is currently looking at. So we'll have more to say about that. But the idea that if you cut yourself or you're violent to somebody, actually that's a no harm event, to me is really quite shocking, because it completely underestimates what's going on for that individual, but also to some extent what's going on for that member of staff that's witnessed these things. You see the majority of incidents happen from lunchtime onwards to 10 o'clock at night. And that probably has real implications when we start to think about staffing. Most mental health trusts operate long day systems. So staffs start at 7 o'clock in the morning, finish 7 o'clock at night. So actually you have this window of an evening time when actually there's less staff available to deal with probably most disturbances on a ward. Historically, we used to have earlies, lates, and nights and twilights that would used to buffer these kind of zones. So if we've got all this incident data, we know all of these things are going on wards, why aren't we thinking about staffing wards in a different configuration? Why aren't we allowing most of our resources to work 9 to 5, Monday to Friday, when actually we need to be thinking about these kind of twilight periods where actually wards become more disturbed? And of the violence and aggression, about 40% was actual physical violence. Again, that puts a huge toll on the patient, and the staff. We know that musculoskeletal injuries are the #1 cause of sickness on mental health nurses on wards. A lot of that comes from having to deal with disturbance in terms of managing that with restraint and restrictive interventions. Huge problems around self-harm we've already kind of flagged, but actually there's two kind of areas we need to think about there. One is around cutting and how we manage cutting of patients on wards, and actually the evidence base around that's not really improved much in the last, the 30 years I've been a nurse. We are still fumbling around with kind of decent interventions that help people to manage their distress on wards. And we also have to remember that, you know, self-harm is a behavioral pattern that people have that predates often coming into hospital and will continue when they leave hospital. And actually, there's probably a lot more discussions we could have around safe self-harming, and actually really thinking about changing that narrative. Self-harm is one of those things that often leads to restrictive interventions, particularly if you're a young woman. And I think there's a whole thing we need to do there in terms of our thinking around changing the management of that. The second really worrying trend was around self-strangulation. So, you know, NIHR have for the last 20 years been championing the removal of ligature points on acute mental health wards, yet we're still seeing people being able to tie ligatures, tie them themselves, or tie them around low hanging objects. And this is another area of concern, really. But it's interesting that, you know, trusts aren't really thinking about this data in a meaningful and clinical way, and actually thinking about how wards could be changed in terms of their proactiveness, looking at the data that they're receiving. So we know wards aren't safe. The incident data is not great. There's a huge variance as well between wards, with some wards being really low reporters and some wards being really high reporters. What that story tells us, we really don't know, and our next study that we're about to launch is going to tell us that, a little bit more detail about that. These aren't indicative of good or bad wards. There's something going on in terms of ward dynamics that we don't understand in terms of how and why some incidents are reported and others aren't. These incident reports really underestimate the harm to patients. If the majority of self-harm is categorized as no or low harm, it's really not thinking in a meaningful way about what patients are experiencing in a clinical setting. It also probably overestimates the harm that staff experience. We know if a member of staff gets assaulted, that's recorded in lengthy detail. If a patient gets assaulted by another patient, actually, that's probably not recorded in as much detail. So there's kind of things that we need to really pay attention to. I don't believe services learn from this incident data. You know, staff are spending an awful lot of time collecting it, but actually, is there a granular level of analysis? Does that really lead to meaningful change on wards? We're all really fed up with hearing about lessons being learned in major inquiries. This is a real opportunity to learn lessons at a smaller, more granular level that we don't see. And we are seeing things that are being missed. So the biggest killers of patients on mental health wards are probably around choking. And that's for a whole manner of reasons. I won't go into it now, but actually it's a real risk for wards, particularly with people with mental health problems and learning disabilities. We pay very little attention to that. And other things like constipation as related to side effects of medication didn't really feature in this data that we were seeing. So is that they're not being looked at, or they're just being ignored, or it's just not on staff's radar? There's a huge lack of focus around psychological safety, you know, so that's about, you know, we're seeing evidence of abuse, but what's happening We're seeing reduced access to justice. So police very rarely attend wards to deal with crime. We've already got patients when they come into hospital are hugely likely to have a trauma background or some kind of iatrogenic harm that predates admission. We're giving them PTSD as a result of the admission and then sending them on their way even more traumatized. So we wanted to look at these safety issues in a little more detail. So we ran out a big survey with staff, carers, and service users. And actually, they were really nice. And we got nearly 800 responses back that looked at kind of 70 different safety issues from around inpatient mental health care. I'll let you just take this in for a second. So this is what staff predominantly told us were the issues around kind of inpatient mental health care. And unsurprisingly, they tell us that there's not enough staff. There's not enough beds, that actually there's issues around competency and resources. The staffing levels within a mental health context have never been truly evaluated. So a while ago, the chief nursing officer instigated some reviews around safe staffing. The only one that was managed to be done was around district general hospitals. The one around mental health got quickly kiboshed. So we still are no clearer about how many registered nurses do we need to have on a ward to make that environment safe. There's a huge problem in terms of the research and the literature. It's not very good. And actually, we have a huge problem in terms of being able to describe, well, what would a good outcome look like? Because we really struggle with those kind of things. How do we know that we've made somebody better or worse? Interestingly, when you look at it from a service point of view, from a service user and carer point of view, they kind of give you a very different picture. They talk a lot about waiting. So there's a drive within the NHS probably to keep referring people on to more and more specialist services. Often those referrals go nowhere. They get held up. You get assessed and got told you're not right for our service. We're operating in a world where resources are becoming less and less. Maybe there's never been as many mental health staff in mental health services. I don't think there's ever been as many consultant psychiatrists as we've got now. So there's kind of an issue there that the staff are telling you there's not enough staff, but the patients are saying, actually, hang on, what I see is lots of waste in terms of resources. So conclusions from that, you're seeing this vicious circle emerge around staffing and that contributing towards individual safety factors. There's something really important about co-production. So if we're going to design things that improve services and improve safety on wards, we really need to have co-production at the center of that. We also did some work with Rebecca's framework and managed to tweak that a little bit in terms of a mental health context. All of that stuff's out there in the public domain in terms of being published. If you look at a more granular level, so if you interview patients around what are these factors and what do they feel like to you, you kind of see these 5 things emerge. So the first is around that priority that's given to physical safety over psychological and relational safety. So acute mental health wards are obsessed around physical safety. They have rules around locked doors. They have rules around windows not being open. They have rules around lots of things on the wards, which kind of wrap a physical blanket around people. But actually, that's often at the expense of thinking about their mental health, their psychological well-being. And actually, we know within all of this mix, relational safety is really important. If you get on well with the nurse, actually that takes away a whole lot of problems. And I think there's a real need to be thinking about this kind of psychological relational safety, particularly in mental health services. If you want to know more about psychological safety, we've done a whole load of work on that. There's a little segue there for you to have a look at, which will take you to a web page, and that outlines kind of some of the work we've been doing there. Service user and individual staff factors. Now, I rant a lot about toxic staff. And actually, it's a really hard sell, but actually there are probably some individuals that shouldn't be working within mental health services. And they may have a whole load of reasons why. It may be that they've been assaulted in the past, they've become burnout, they've become demoralized. There's a whole load of occupational health stuff we need to wrap around them. But actually, we also know that institutional settings do attract people that like to be bullies and like to be power hungry. And I think we've not done a very good job professionally as nurses in terms of understanding who needs help and actually who really shouldn't be in that job. And if you've heard me talk before, I've talked quite a lot around toxic staff in the past, so I won't start ranting now. But it is something we need to pay attention to. We also know that when staff try and intervene in situations that are escalating, de-escalation as an intervention is probably the most complicated thing you can do. It requires you to be really self-aware, really grounded, to not be buying into the adrenaline that's running through your system, and at the same time being able to be calm and rational to somebody who's really distressed and becoming increasingly angry. These aren't low-level skills. These are high-level skills that require an awful lot of training. I don't think mental health services or mental health researchers have taken this stuff seriously. You can't learn this stuff in an hour's PowerPoint presentation. It takes years and years to develop these skills. Again, we're seeing the issue around self-harm. We know self-harm really does trigger negative attitudes in staff. And actually, the kind of attitudinal research suggests that the more you expose to this stuff, the more worse your attitudes become around mental illness and mental health. If you're a professional, if you're a member of public, it's actually the opposite. So the more we talk about mental health and mental distress, actually, the better your attitudes get. Not so much for staff. So there's something clearly going wrong there. The social environment, you know, we banned mixed sex wards. You know, they were banned by NHS England a long time ago, but you still see this kind of gender mixing on mental health wards. This is hugely problematic. You've got people that may have been, abused in their childhood, traumatized, being exposed to male patients, and the other way around, male patients being exposed. And actually staffing, we really need to think about that complement of staffing on wards as well to make sure there's a dynamic mix of gender, but also ethnicities, and actually the wards are reflecting the population that they're looking after. Huge thing about that kind of therapeutic environment. The wards aren't designed with therapy in mind, but actually there's lots of stuff we could probably do in this space around making things feel better, particularly if you think about, a ward that's autism and neurodiverse friendly is probably not a bad place for everybody. There are things in terms of design that we could do in terms of lighting, noise, stimulation, soundproofing that would actually make the environment feel more therapeutic. We'll skip that one. So there's little research around how do we get patients to tell us when things are going wrong on wards. And the bit of research we did gave us some clues. So generally services don't like to listen. They don't like to get complaints. They don't like to have feedback. They don't like to respond in a timely, reflective manner. That if you've ever worked in an NHS organization, complaints, they go up a separate channel, they get dealt with, and then that stuff doesn't really feed back. You never get that feedback loop around things are changing. In a mental health setting, it's probably really concerning that actually patients are concerned about repercussions. And certainly there's lots of examples where if you put a complaint in on a ward, your diagnosis suddenly changes. So you get labeled having a personality disorder, you get discharged from services, you get discharged from the ward. Actually, there's a real narrative there that has been explored by patients and service users around just how services don't like to be challenged and how that can actually influence the course of treatment you're going to receive. And what we need to really remember is that when you're on a ward and you're detained under the Mental Health Act, you're unwell. And being unwell actually is really detrimental to your ability to process information. So we know that people with psychosis and their ability to process information is impaired when they're unwell. The ability to cognitively understand things, the ability to communicate, all of these things are kind of impeded. So is it any wonder then that patients don't really feel in a place to actually start helping us to make services safer? Okay, let's move on. So the solution, how do we get to proactive care? Well, we go back to the beginning. So the very first paper I wrote, and I still can remember walking onto a ward and actually feeling that tension in the air. There's something about when you walk into an environment, you can, as a human, you can feel that tension. And if I can feel it as a member of staff, then we know patients are more likely to feel it. There's something called the stress vulnerability model, which suggests that actually, if you're unwell and you're distressed, that actually you're more sensitive to the environmental milieu, you're more sensitive to interpersonal connections. But if we could capture that in real time, so if patients could say, hang on a minute, this doesn't feel quite right, and make staff do something about it, are we picking up those really early cues before somebody gets distressed, before we try and de-escalate? And this was where ward sonar came in, that actually what we wanted to try and do was think about developing a way where we could actually predict when incidents were likely to happen based on that milieu. And in mental health, there's a whole literature around milieu and therapeutic environments that dates back to the 50s and 60s, where they had therapeutic communities. We kind of can articulate what milieu is, and we know kind of how to manage it. But some of that knowledge has got lost. And if we do prevent incidents, actually, we could probably prevent contagion. So we know that when one incident happens, there's an increased likelihood of another one happening. And this contagion, I know some patients don't like the word, but contagion actually spreads around the unit. It's not just about one ward. You got to remember when staff go off to a ward and deal with an incident, when they come back, that first interaction they have with other patients or other staff brings that contagion back with them. It used to be after an incident, you'd go off and you'd have 5 minutes, you'd have a cigarette, or you'd calm yourself down before you came back. Those kind of practices have long gone, but actually there's something about post-incident, what do we do to rebalance ourselves, to make sure that we don't spread contagion to cause another incident? And most challenging of it all, if you prevent an incident from happening, how can you even prove that? We can prove it from kind of randomized controlled trials and that kind of stuff. But actually, from a philosophical point of view, how do we prove this stuff is working? It can be a challenge. So we designed an intervention with lots of co-production and lots of patients on wards. We did all this during COVID. It wasn't an easy task. But actually, what we got to was a very simple way of asking patients to tell us in real time what that ward felt like in terms of an atmospheric measure. And we used the weather as an analogy. So, does it feel calm and sunny? Right through to is it stormy? Is there real problems going on? And kind of, can you tell us which direction that's going in? So if it's stormy, but actually it feels like it's getting better, that's really important to know. But actually, if it's calm and it feels like it's getting worse, actually, they're probably the cues we need to start picking up on. Obviously, we need to design this in a way that was most accessible to most of the population on wards. Thinking about language, thinking about individual learning disabilities, low literacy levels. There's lots of stuff around digital exclusion and people with severe and enduring mental illness. So we had to design it in a really thoughtful and careful way. We also wanted to know some of those things that were contributing to that milieu. So, was it Fred's just walked on shift, and we know when Fred comes on shift, there's going to be an incident because he's going to go around prodding patients, not literally, but emotionally prodding patients. He's going to be the one that triggers all of these incidents. Or is it other patients? We know that, when you're distressed on a ward and you start shouting and screaming, that's really going to impact on other people. So there's things we could find out in terms of those kind of contributing factors. And we zoom this as soon as the data went in back to staff in real time to give them a real cues around what was going on in the ward environment, even to the point where we had very simple kind of swinging thingamajiggy, I can't remember the word for it, which would give a real-time presentation of the direction of travel in terms of the ward. Interestingly, we debated this at length about whether we would just show this on a screen on the ward for patients to see as well as staff. And whilst everyone felt that was a really good idea and actually gave real ownership to the community in terms of managing that feeling, that therapeutic milieu on wards, the PFI just got in the way. So putting up a screen cost thousands of pounds of money. It just made things really impossible to do. But I think there's something there around kind of community ownership of the milieu on wards. And I mean, if you look at the literature around therapeutic communities, actually that's how it's run. You know, it is a community. The community deals with problems. The community talks about solutions. So where did we get to? 6 acute wards in the middle of a pandemic. We managed to get it on wards, which was a massive achievement in and of itself. We managed to understand that nature, that complicated nature of contagion and milieu, and how both staff and patients contribute to that. We were able to use some tech, although there's huge problems if you ever try and do something in the NHS with technology. In the end, we had to jump on the patient Wi-Fi because they wouldn't let us go anywhere near their systems. And interestingly, it made them fix the Wi-Fi because on some wards, the patient Wi-Fi wasn't working, hadn't done for a long time. So that's a win in and of itself. Key to all of this stuff, though, is having research champions on wards. And what we noticed when those champions weren't there, tablets got locked in offices, charger cables went mysteriously missing. All of these day-to-day problems we know about in terms of getting nurses to help us deliver research on wards. And actually, on really volatile days, the devices didn't come out. And, you know, if I was a manager and suddenly the data stopped flowing, that would give me a real cue that I needed to go and have a wander around and see what was going on the wards. So the absence of data is just as important as the flow of data. And I think that's part of this idea around proactivity. It's not just being passive in this process. Patients liked it. They really liked it. They like being able to give that instant feedback. It's dead simple. I mean, I don't know whether anyone's seen the old patient safety thermometer that they used to have in mental health. Used to go around once a month and collect this data, and then you never saw it come back. So it was real time. And actually, this was another point of contact when staff were bringing the tablet around. It actually was. It was another point of contact. And there's a huge problem with nurses not being visible on wards, particularly mental health ones. So, you know, that was another bonus from this system. Staff increasingly saw collecting this data as just a task. And part of that problem was actually they weren't paying attention to what was coming to them in terms of data. So they weren't changing their practice on the basis of knowing that things were getting worse or better. They weren't really looking at the real-time data. But again, that's not an unusual finding with the work that we do. And a few staff knew it all already, and you'll always get that. They already knew their patients and their ward atmosphere. They didn't need this intervention, which again is fine. But actually, you're getting loads of incidents. So what's driving that? I am watching the questions as well as they flow in. Don't worry, I'll try and pick them up afterwards. Key messages then from that masses of data that really hurt my brain in terms of all the math stuff. There was huge differences across the wards around incident probability and submissions of data. One patient giving you a stormy response actually was a really good predictor of an incident within the next hour. And we were able to prove that actually there's really strong evidence that if you've had one incident within the next 3 to 4 hours, if you don't do something about it, you're going to get another one. And this is the first time we've ever been able to categorically describe this nature of contagion, this measure of contagion duration, which we've all talked about for years, but actually no one's ever done any research on it. Clinical implications. If you're a nurse on the ward and you've had an incident, don't disappear to the staff office. Take a breather, rebalance yourself, but actually that's the time to get out on the ward. It's the time to check other patients are okay. Patients often witness restraint, they witness self-harm, they witness distress. Actually, stop them stewing on it. Let's do something about it. Let's do some activities. Let's open the windows, increase the ventilation, change the music on the radio. There's lots of practical things we could do. We could even have a safety huddle and then move on from there. we need to also think about that variation in incident numbers across wards. And it's not about patients. Mental health is terrible. It's spent years and years trying to identify violent patients or patients at risk of this or that. We've paid no attention to staff, and actually it's a complex situation that we need to think about in more detail. And actually, you can have two wards next to each other with exactly the same patient populations, and one ward will be really disturbed and distressed, and the other one won't. So what's going on there? Is that around leadership, clinical leadership? Is it just about the mix of people on the ward of the day? We don't know, but actually, we're going to know a little bit more about that in the next few years. So what do we do? Well, whenever you talk to intelligent people, they tell you need a randomized controlled trial. But this would be a cluster randomized control trial, which means you need 16 wards in each arm. Convincing the HTA to give us 2.5 million for this really novel and wacky intervention hasn't so far been successful. And they've even fed back to me that they don't think incidents are a patient-related outcome, which I find really difficult to deal with, because actually we know that incidents cause distress, they increase your time in hospital, they increase your exposure to antipsychotic medication, they lead to restrictive practices, they cause you harm both physically and psychologically. So for me, maybe I didn't articulate that well enough, but I think I would have done. So there's something about outcomes in mental health we probably need to think about. Or we come up with a plan B. And that's what we're working on at the moment. We've got a great intern that's been funded by the university to make our code open access. We've got some launch materials coming from Nifty Fox, and we're just going to drop it out there and see whether we can get a trust that would like to adopt it, and see whether we can learn and evaluate from that in terms of process. Quick plug before I finish, take a breath, around our next study, which is called Staffed Wards, which is doing the stuff we haven't done so far, which is linking incidents to staffing characteristics and seeing whether we can actually, not that I'm allowed to call it that, find those toxic staff in the mix and do something about it. So that's the end. What was that? 40 minutes, Rebecca. That's not too bad, is it?
Absolutely perfect, John. Thank you.
Stop sharing, and then hopefully we can get to some of these important questions.
First of all, could we all give John a round of applause for an excellent talk? Thank you. Can't hear everybody, John, but at least you got my clap there.
I can see loads of claps. That's really nice.
Great, lovely. So do you want me to read the questions out, or do you just want to take them yourself?
I can see them, so I can.
Great. Okay, well, I'll leave it to you to.
So first question, Jenny, how do we keep champions engaged? So on some wards, it was easier than others. So some wards, there were people that really embraced the technology, that really embraced the vision. And I think there's something about currency as well. I'm able to go there as a mental health nurse and talk as a mental health nurse to some of the issues and some of the problems. And I think that helped. I think other wards, we didn't get the champions in play as well as we could have done. I think there's a lifelong lesson there, isn't there? If you ever want to do anything on wards, then actually you need the ward manager and you need a champion, and that doesn't have to be a registered nurse, but actually you need people to drive this stuff. And where we got that going well, it worked all right. It was at the height of the second wave of COVID, which was just a nightmare. It caused real problems for researchers on the ward and the staff and the patients. So if we could do it again in a less distressed time, that might be good. Acute wards have been distressed for years, though. I don't think COVID made things particularly better or worse. Olivia, how did this provide insight into how how's work together? It didn't really provide insight. I think there's something I want to do, which is actually at a more granular level, look at who's on shift and how that relates to incidences. Because actually, I think there's something there at a real granular level. We tend to look at ward level data or hospital level data, but I think there's something really interesting about, we know that sometimes staff collate together, group together when actually they are all the demoralized ones come on shift and all the really positive ones are on a different shift, and staff have some say in terms of rotas and timetabling and who they work with and won't work with. I think that's the missing piece in this jigsaw puzzle that I really want to get onto. Alison, no, high level skills aren't recognized. What you see in mental health on wards is that it's a test ground for newly qualified staff. So they go there having just qualified. We don't get a really good retention rate. And actually, when you think ward managers are only graded at a band 7, is it any wonder that you get kind of a brain drain towards the community? You don't keep that that vibrant skill mix on wards for very long. There's a constant churn. And actually, of all the places, acute mental health wards have the lowest, the highest vacancy rate at the moment. So it's not a good time or good place. Jamelia, I don't know about the dashboard contributing to contagion. So it's one of those things we debated at length, and I think it would work. It could work either way, and unless we test these things, we don't know. My hunch would be that actually patients could say to staff, "Look, things are getting worse. Can we have a community meeting? Can we tell you about why?" So it almost becomes like a trigger for staff to become more responsible for doing something about the ward environment. There is always that fear that actually you're telling people things are getting worse, and that contributes to things getting worse. Unusually, I'm usually a half glass empty person, but actually for this, I actually felt it would be the other way, but we don't know. We may never know. We do need to pay more attention to training and supervision of support staff on wards. You can walk onto an acute mental health ward as a support worker, probably with a few weeks training. The majority of that will be around dealing with violence and aggression. So that'd be the control and restraint course. So largely, I know it changed over time. There's more emphasis around de-escalation, but they do teach you an awful lot around physical holds and restraining people. When I used to be a clinical nurse specialist, we developed a whole new course for support workers, which was more around the psychological side of things and actually trying to help people deal with distress and real kind of low level interventions. It's not mandatory, it's not very good, and there is no national standards. William, no, nothing's been tried on acute mental health medical wards, but actually I thought, when I was thinking about this, it could be really great in prisons. It could be really great in schools. I know my colleagues in Denmark want to use it in Denmark, and actually in Denmark, patients would just download the app. You wouldn't even need staff to take things around. But I think there's something around the nature of institutional settings, and when tension rises, it causes a huge manner of problems. And to be able to capture that in real time or post real time, to think about that, I think there's real potential, and it's dead simple. That's the key to this. We work really hard on making it simple because most interventions are hugely complicated and therefore become really problematic with patients. So maybe it would be nice to try it on a general hospital and see whether patients tell you the same thing. I know when I've been in hospital, I know when my family have been in hospital, it's often the patients are saying to staff, that person's not very well, or there's something wrong here, or, and we don't hear those signals if we're busy and running around. Hayley, I will contact you. Rachel, priorities for change. I think that's a really tough question. I don't think I'll answer it now, but I'll email you afterwards, and maybe we can have another discussion about. Will, another question from you around hijacking. Yeah, we can discuss this afterwards, Will. You know where I am. Rebecca, what do you want me to do? Keep ranting on these questions, or do you want to open it up to a bit more discussion?
I think we've got a couple more questions, and then we will open it up to discussion after those. So there's one from me, and I think another from Jamila. Yeah.
So in terms of the way it worked, so largely from a governance point of view and data point of view, all data that was put in was anonymous at source. So the staff never knew which patients were saying what. Although you could put in some qualitative narrative if you wanted to. So if you were saying Fred next door is being a right pain, the data was presented back to the environments at a ward level. So theoretically, you could have identified people, and staff did take the device around. So, they probably knew who was putting in or didn't put in. But actually, I think there was a point of principle around, the things we'd learn about how difficult it is to make complaints, the concerns about repercussions. Actually, you want to make this stuff anonymous. You want to make it as easy to use and as friendly and less worrying as possible.
I can ask it in rather
Go
than.
on then. That'd be
Go
nice.
on.
Yeah, so I guess I'm a clinician, so I have to declare my conflict of interest in this one. But I think when you started, you really got me to think about the structural and system issues, like because staffing actually came out quite big in both kind of word clouds. I thought, as well as wider stuff. Whereas this, it seems like at the moment anyway, it's kind of all it's doing is, so there is this stuff going on in the ward. And then the ward manager now has an extra piece of information. But actually, yeah, is it just going to be a stick to beat ward managers with, rather than actually them going, something going on this ward that this current staffing skill mix or levels of staffing isn't managing? So how do you actually put in additional support? I don't know. It just feels like it might end up being just another stick to beat.
Yeah. I'm not convinced. So I think there's something really meaningful about actually staffing was only one component of the feedback, and we know that other patients really contribute towards the milieu. And if organizations implement it like a task, this has to be done once a day, and you have to, then it becomes problematic, I think. But actually, what we know, and there's been a number of studies where they've actually got ward staff to keep diaries. And because of the way that things work, and actually, if you look at the 3 previous chief nursing officer reviews of mental health nursing, one of the biggest recommendations was the reduction in paperwork. So there's something really wrong about the way we deploy our resources on wards, where the registered nurses end up sitting in the office all the time, doing the paperwork and only coming out when there's a fire to fight, rather than actually us saying, well, actually, we could rationalize so much of this paperwork and enable you to be out on the wards more, doing the stuff that we train you to do, which actually was around milieu and being therapeutic. Unfortunately, the other part of the jigsaw puzzle is when they've done the protected time studies and actually gave mental health nurses time to spend with patients on wards, nurses really struggled because we're not training them with that toolkit of psychological interventions we need them to have in order to feel like they can be therapeutic. So there's something really wrong in terms of the way we're equipping staff, training staff, and then deploying them on wards. It's probably at a system level that makes things really bad. But I think this is about the trusts or the ward manager's vision about deploying this thing. If you can prevent one incident, you reduce the likelihood of that patient's being in hospital longer, being exposed to coercion, and all manner of other traumas that they're going to experience. You're also protecting your staff from trauma, physical harm, when you think about sickness. So if you've got that vision, actually, I want to stop these incidents from occurring, and you deploy it in that vein, then actually I think it's about the way we sell it, the way we think about it, rather than allowing it to become just another stick that we beat staff with. But I get your point, and it's highly likely it will become another stick.
Thank you.
Any other questions to start a discussion with John in the last few minutes? Just going quickly through the people, John, but I can't
I think I've covered every question apart
You
from
have
I need to
covered
get
every
back to
question.
Rebecca. Not Rebecca, Rachel.
Yeah, that's right. And which you'll follow up
Yeah.
afterwards. That's fantastic. Thank you. I wondered about the piece that you mentioned earlier about people being in their offices. We hear that a lot in the work that we do in these settings, and they're kind of hiding away. They're doing work that is safety work, but it doesn't actually contribute to safety, as Drew Ray was talking about last week. How much of that is is related to the emotional burden of doing the real work? I'm really interested to understand more about that, because you've talked about perhaps competence and some of the skills that people might not have, which probably contributes to the emotional burden of going out there and doing that work. I just wondered if you had any thoughts on that.
Yeah, I think part of it is that we've geared up the paperwork to become this never-ending beast, and actually, and this is a challenge we all need to challenge services with. Is we always introducing new forms, new checklists, new systems, and actually we very rarely take things away. So on a ward, what would be the minimum we needed in terms of an entry around nursing notes? What would be the minimum we needed in terms of a data set? And maybe AI will help with some of this stuff, because patients always tell you they're always repeating their story, but nobody ever listens to it. So, even though we record things at great length, nobody ever reads it and learns from it and listens to it. So there's that part of the jigsaw puzzle. The other part I think you're really right on is actually robust clinical supervision is dead important to keep staff vibrant and healthy. It's often absent from these wards, and there is a role for clinical psychologists to help with some of that processing stuff. But actually, supervision is often managerial and therefore not very supportive and caring. We also need to think about the offer around CPD. So nursing doesn't get great CPD. As a nurse, I think I only have to do 30 hours of CPD every 3 years in order to re-register. There isn't the vibrancy. So there's a difference between training somebody with PowerPoint slides and blah, and actually commissioning real high quality learning where people are able to role play these skills, learn about de-escalation theoretically and practically, and actually put things in place so that they're reflective after an incident and learn and grow that way. All of that stuff's pretty much absent, but it's not just a mental health problem. I think that's it's absent across the NHS in terms of enabling our clinicians to grow in a meaningful way.
Thank you so much, John. And Jess has just joined us in the decluttering theme, so I'm sure there'll be opportunities for teaming up with you to do some work around decluttering in mental health, which would be a great opportunity. Anybody else before we finish and thank John one last time for a really thought-provoking talk? And there's much that you talked about today, John, that I think we could apply to lots of different healthcare settings too. So thank you. Oh, Jess.
It's okay, don't worry. Hi, John. Thank you for your presentation. It was really interesting. I've just got a couple of questions. So my first initial thought about the use of the ward turner tools, I'm trying to think about how it would work in a ward setting. And I know you said about it being anonymous and the value of that. I'm just wondering whether patients would almost use it as an opportunity to share distress, because I know some of the questions that are on the ward turner that you put on the screen where they could click stormy, but they could also say because of how I'm feeling. And I'm wondering whether, patients on a ward might almost use that as an opportunity to share some distress that they felt that they may not be able to share otherwise. And if anything would be followed up if a patient, because I know you said it's anonymous, but if a staff is member going around and asking these patients and they are clicking it stormy and it's because of how I'm feeling, is there any sort of follow-up process in that? And then I've got a second question about champions, but I'll let you answer that one first.
So maybe we're going to run out of time, so we'll save the champion question for another day. So it's tricky, isn't it? If you make it a feedback system that's about individual distress and somebody puts something into it and staff don't act, then actually, as a registrant of the NMC, have I failed in my duty? Have I failed in my care? And so there's a whole layer of ethical and moral problems that we kind of thought through in our journey to make ward sonar, which wouldn't make the individual collecting the data accountable for reacting or not reacting to messages going in. And what we need to remember is that in a mental health context, if something happens on a ward, you will end up in coroner's court. I'm not sure how many of you have been in coroner's court. I have, as a result of a patient dying. It's a hugely emotional and hugely terrible time for the family and the staff, and actually nurses are exposed. You know, it's only a couple of weeks ago that mental health nurse ward manager was the one that was prosecuted because of bin bags on wards. And we need to be really mindful of that. And so it may seem really obvious, but actually there's a whole layer of trickiness and thought that's gone into why would we make that decision and not another one. But we're out of time. I'm happy to talk to you in more detail if you want.
Thank you so much, John. It sounds like there might be a few people that will be following up with you afterwards, which is always the purpose of these talks, isn't it? To build networks and relationships. So thank you once again for taking the time out of your schedule to come and talk to us today. Very much appreciated. There will be a recording of this presentation that will go on the YQSR YouTube channel, so please do mention it to your friends, everybody who's attending today, and thank you again. Goodbye.